Kia ora, welcome everyone to this Goodfellow Unit webinar on diabetic retinopathy with Dr. Narme Deva. She is a consultant ophthalmologist in Auckland and specialises in medical retina, uveitis, and is an expert cataract surgeon. Welcome, Narme.
Thank you, Helen. So hi, everyone. I wanted to talk about diabetic retinopathy, mainly how it pertains to the primary care physician and also recent developments in the management and also a new technology that we have. There is no doubt that the global burden of diabetes is exponentially increasing. In New Zealand, we have more than 250,000 people affected with diabetes, and approximately 1/4 of those have some form of diabetic retinopathy. Diabetic retinopathy is a global term. It refers to a combination of diabetic macular edema, which affects the central part of the retina, so it has a significant impact on your vision quite early on in the disease process of diabetic macular edema, and also peripheral diabetic retinopathy, where there's abnormal growth of blood vessels and blood vessel changes in the peripheral retina that can cause significant vision loss from bleeding. And it's a significant concern because it affects the working age population and is a serious cause of visual disability. We don't really know exactly what the prevalence of diabetic macular edema is because it can exist for a long time before it becomes visually significant. But if you look at the various studies around the world, the incidence rate's around 1 to 15% worldwide. While I'm going to be looking at diabetic retinopathy and macular edema, it's important to realize that there are other ocular consequences of diabetes. So when a patient comes to you who's got a long history of diabetes, they can actually have ocular surface issues associated with it, like dry eyes or poor wound healing. It's one of the reasons why we're pedantic about blood sugar control when we do cataract surgery and things like that. Cataracts themselves happen at a much earlier age in diabetics than a non-diabetic population. And when you do cataract surgery, there are consequences from doing the surgery on the diabetic retinopathy and maculopathy. And it's really important that that is managed, and it's a priority for us. So those of us who do a lot of cataract surgery and look after a lot of diabetic eyes are very well aware of how not managing it appropriately has significant long-term consequences to the patient's visual outcome. And finally, an entity that is often underrated is the actual damage to the optic nerve from ischemia caused by diabetes. And it doesn't have a ready manifestation in the nerve till there's a lot of damage done, but often when we can't figure out exactly why a diabetic person is not seeing very well when there's no significant macular edema or retinopathy, it could be the nerve. And unfortunately, nerve damage there is something that we can't fix, that we can't sort of restore the vision that's lost from there. But as I said, the main reasons are diabetic macular edema affecting the central vision and the peripheral retina. So over the course of this webinar, what I wanted to look at is really where the primary care physician fits in managing diabetic retinopathy, and also just briefly look at the very well-established definitions of diabetic retinopathy and the management that we have for each of those different categories. There have been some recent significant changes in the last 5 to 10 years in the context of how we manage it, and it's got a significant impact on the disease burden, particularly for ophthalmology, and how we're going to cope with this ever-expanding treatment that we're going to have to give. And another thing that I'd quite like to touch on at the end is this new disruptive technology, how we've got artificial intelligence and algorithms from there. Really, they're going to play a big role in how we manage the diabetic retinopathy moving forward. So any ocular manifestation of diabetes in terms of vision, it's largely asymptomatic until it's at an advanced stage. And then it's usually, you've missed the boat a little bit. And early detection and prevention are imperative in this situation. Nothing is a better outcome than early detection and prevention in the context of diabetic retinopathy management. And where the primary care physician fits in is recognizing diabetics and making sure that they go for the screening systems that are established in New Zealand. I've worked in quite a few different countries, and I'm quite proud to say that while it's not perfect, New Zealand has actually got an excellent screening diabetic retinopathy screening system, and that is quite integrated compared to the UK and Australia. To start off with, you're screened every 2 years. And it's the primary care physician's responsibility to ensure that that is initiated and that the patients keep going on with it. The second crucial role is really the management of risk factors for diabetic retinopathy. That is done by you way more than someone like me who will touch base with them maybe every 6 months or 12 months initially, until you've got to that advanced disease stage. And then, like I said, you've missed the boat a little bit. And primary care physicians are key in making sure that the diabetic patients are engaged in the health system, because what I do to my diabetic patients is not pleasant. And I have to do it frequently, and they get to see me really often. And when I go through this, you'll realize that it's actually really hard to stay committed to that. And that's where the GP comes in, because we do rely on you helping us, making the patient come back to see us when we need to see them. So the Ministry of Health, this statement that you see on the screen is from the Ministry of Health document. A steering group was established in 2016 that really sort of spruced up the established guidelines. And it mainly focused on type 2 diabetics and pregnancy, but it has a really good overall perspective. And I've kept a link there which leads you, which puts you onto the PDF that is the guidelines from the New Zealand Ministry of Health. But in summary, the primary care physician refers, and then the screening responsibility is on the DHBs, the 20 DHBs throughout the country. Each DHB does it slightly differently depending on its local models, but it does it according to national standards. And this is one of the flaws in the screening system. It's not fully integrated. Some are optometry practice based, some are hospital based, imaging based, looking at with an ophthalmologist reviewing the images, or a combination of all of the above. And then the results are provided to the patient, the general practitioner, and if the referring physician, if the person's different, in a timely manner. And if there is any intervention that's required, then they're referred to a medical retina service within the appropriate DHB. And there are designated ophthalmologists that oversee this diabetic screening process for each of the district health boards. Generally, a type 1 diabetic is enrolled 5 years from diagnosis. For children with type 1, it's either at the age of 10 or 5 years after diagnosis, whichever one comes first. For type 2 diabetics, they're enrolled at the time of screening, because often these patients may have had diabetes for some time before they're diagnosed. The standard screening is 2 years, but depending on the clinically modifying factors which the screening service will look at, that can be extended or shortened. And as I said, the designated ophthalmologists provide oversight again for this. I just wanted to mention pregnancy, because this is something that's commonly asked. So if you develop gestational diabetes after 20 weeks of pregnancy, you don't need screening for diabetic retinopathy. But women with type 2 diabetes that are newly diagnosed at the beginning of their pregnancy definitely need to be screened. And then a known diabetic, while they're during conception, planning their conception, the pregnancy, needs to be very closely monitored depending on the degree of diabetic retinopathy. And that can be quite variable, and I'll talk to that a bit further. One of the hindrances for people going to screening is often the pupil dilation, and the New Zealand Ministry of Health outline says that it is optional. So we can get the imaging that we want without pupil dilation, not in everybody. So small pupils, which happen in diabetics, or dark colored irides, it's sometimes difficult, but the option is there for patients. If your pupil's dilated, then they can't drive or use heavy machinery or anything like that for a few hours afterwards. Their vision's blurred, particularly their reading vision. So it can be a bit of a roadblock to coming to the screening. So it's worthwhile telling them that that is an option. And they may be disappointed when they get there and we can't do the imaging, but it is technically an option for them to not have their pupils dilated. So at the screening, they get their vision, they get the imaging, and then they review clinical factors that may modify what that screening interval is. And if it fails because they can't get a good image or there is actual pathology, then they're referred to someone like me. I think it's really important to remember that even if someone's getting the screening every 2 years, it does not constitute a complete eye examination. And there are loads of other things that can happen, that can go wrong in the eye, and they can happen in between those screening intervals. And so it is important when a patient comes to you to consider that and refer appropriately, even if they are within the diabetic screening network. So the second parameter is really modification of risk factors, and the general practitioner is integral to this because you provide that holistic care to the diabetic patient. There are obviously non-modifiable risk factors like the duration of diabetes. So practically every type 1 diabetic after 20 years, and about 60% of type 2 diabetics after 20 years will have diabetic retinopathy. So it will definitely happen. But there are a number of things that we can do, that you can do to mitigate how soon that will happen. Poor glycemic control and uncontrolled hypertension are major risk factors for progression. I'll go on to the next slide, but there are a couple of very good landmark studies that were done in the 80s or the sort of 70s to 90s in the UK in type 1 and type 2 diabetics that very clearly outlined that if you look at good tight glycemic control and good blood pressure control, you dramatically reduce the need for intervention in the context of diabetic retinopathy, as well as pregnancy and rapid marked improvement in blood sugar control. I'll talk to these a bit more in a moment. Renal impairment is interesting because I don't think it's more a risk factor, but it happens in conjunction with, if you've got microvascular disease in your eye, you're pretty much going to have it in your kidneys and vice versa. And so if you have renal impairment, then we really look hard for diabetic retinopathy and the other way around, really. And dyslipidemia and smoking are also interesting. I'll talk to those in the next couple of slides. So these are it's a busy slide and it's really just for your information later on, but these are the main trials that looked at the impact of glycemic control and blood pressure on the development and progression of diabetic retinopathy. The HbA1cs are in percentages, but really tightening up that glycemic control had a massive impact on the risk of developing and the risk of progression. And this is what I mean by the time they come to me, we've missed the boat, really, because I often say to my patients, a 10% reduction in your HbA1c reduces the likelihood of me having to do bad stuff to your eyes by about 40%. So it's worth fighting for. It's worth focusing on. And the same thing with really tight blood pressure control. The UK PDS study, again in the 80s, recruited a large number of patients, and it showed that tight blood pressure control had a significant impact on reducing the risk of developing and progressing in the degree of diabetic retinopathy. The EDIC study was a follow-on study from the DCCT study, and I mention it here because it showed a legacy effect. So if you had a period of tight, good glycemic control, and then it laxed a bit, but you developed the good habits, then you had the limitation of progression and developing retinopathy lasting for years, decades afterwards. The likelihood of having ocular problems related to diabetes reduced by, I think, close to 40% after a period of intensive control for years afterwards. So early habits, early establishment of good glycemic control has a significant legacy effect on development and diabetic retinopathy. The studies also looked at aspirin, and this is a common question because, you know, you've got bleeding at the back of the eye from the diabetes. Is this an issue? So there is no benefit in putting patients on aspirin, and there's no risk of ocular hemorrhage from being on aspirin. Warfarin, Pradaxa, all of that is a different issue, and we would do that on a case-by-case basis, obviously. Lipid-lowering agents is, the jury's a bit out on that. There was some weak evidence that statins help limit the progression of diabetic retinopathy, but we haven't really caught on to that. More recently, with the Accord and Field studies, fenofibrates, which target triglycerides, have definitely been shown to reduce the likelihood of need for retinal laser, which is a sign of advanced diabetic retinopathy. Fenofibrates are not available in New Zealand. The endocrinologists, as far as I know, haven't sort of bought into this too much, and so it's not commonly practiced. But my Australian colleagues certainly do feel that there's a benefit in that component. Smoking. So there's no actual data, apart from some loose data from epidemiological studies on whether this is really bad in the context of diabetic retinopathy, but it's really bad for the eye. And so since it's all affecting the same thing, I lump it together and say smoking is really bad, which I don't think is a novel concept. So this is what I say to patients: a 10% decrease in your HbA1c, 40% less chance of me needing to stick needles in your eyes or laser your eyes. Aiming for a particular HbA1c is difficult because obviously you want to mitigate a risk of hypo if they're insulin dependent. But generally in the low 50s is great. You know, I come across HbA1cs of hundreds. And so low 50s is fantastic. And I do stress the legacy effect. And I think a lot of it is establishing good habits. Aiming for a low, tight blood pressure control, good cholesterol control, and no smoking. So this is just the general advice that I spiel off at the end of every consultation that I have with a diabetic patient, no matter what their state of diabetic retinopathy is. High-risk patients. So these are patients who have diabetes, who have a risk of quite quick progression through the different stages of diabetic retinopathy. And often these are patients who have had really poor control and then in a very short space of time tighten their control. And this happens when they've been on oral hypoglycemics and you switch them to insulin. It's the most common scenario, and then their retinopathy transiently progresses rapidly. Depending on where they start, that progression could lead to vision loss. So it's an important period to mind. If they've got severe retinopathy and then they really tighten their control, then they can go into proliferative retinopathy that will bleed and cause issues. Whereas if they're mild, you know, we'll get over the hump and it's not such a big issue. Pregnancy is an issue. In this setting, diabetic retinopathy can be accelerated. There are 4 factors that influence the acceleration. So if you have poor control at conception, that's bad. You know, ideally, if you're a known diabetic, you need to get good glycemic control 6 months before and then get pregnant and then get monitored throughout the course of the pregnancy. A big magnitude of improvement, and we see this quite often, is everyone sort of is pregnant and then their glycemic control gets amazingly good because they're really closely monitored, and then the retinopathy gets worse as a consequence of that. And so that's another scenario. And certainly the worse the diabetic retinopathy is at the time that you get pregnant and throughout the pregnancy, the worse the risk of progression and the higher the risk of progression is, and coexisting hypertension. So those are really the 4 main factors that really influence how quickly the retinopathy progresses. It does regress postpartum, so it is just a hump, but it depends on how severe it is. So if you develop new blood vessels and have a massive bleed, it's not going to go away by itself. We're going to have to do something to make it go away. But if it's just a little bit of worsening from mild to moderate, then it will actually just improve but it can take up to 12 months postpartum. And so again, depending on the severity, how long we monitor and how closely is dependent on that. There are some guidelines on screening in that same document, but basically it just needs to be highlighted that if you get pregnant and if you're diagnosed with diabetes or have pre-existing diabetes, you need to be screened quite closely, and the screening program will take that on board. It's built into that.
Narme, just before you move on, does the accelerated tightening that you have out of pregnancy up here, does that regress as well, or does that depend on how, just with your tightening of glycemic
I
control?
think it does regress. It does regress, but again, it depends on whether you've gone past the hump. So anecdotally, they're usually poorly controlled on the oral hypoglycemia. So they have moderate to severe retinopathy, and then they go on insulin. And within 3 months, you see that they've gone to proliferative, and there's blood vessels everywhere, and we have to laser and do injections and all of that. When it gets to that stage, it doesn't regress by itself, at least not to a stage where you can prevent vision loss or get an improvement in vision. We have to do something. So yeah, I think it probably does, but it will take 12 months, definitely 6 months, but more likely 12 months for it to go away.
And with input from an ophthalmologist.
Yeah, much quicker with input from us, but yeah. And I also say it's like me putting a finger in the hole in the dam if their HbA1c is like 90 and I'm doing all of this stuff, because I'm not getting on top of it. I'm still just treading water till you sort yourself out to get to a stage. Otherwise, we will just, it's a losing, it has really bad outcomes. But yeah, so I think they do get better with time, but it really just depends on the state of the retinopathy. So I'll move on to classification and management of diabetic retinopathy. So in ophthalmology, in this context, I think we're actually very lucky. For 20 to 25 years, we've got very clear guidelines, very clear definitions, and exactly what to do when something happens, thanks to some amazing studies. So up until quite recently, the management of how we deal with diabetic macular edema retinopathy was very well established for me. It wasn't something that I had to figure out for myself. There are very robust studies that help you along the way, and I've listed the studies there. I mean, the vitrectomy study is from the 70s, so they're old. They're old studies. We've got newer ones, but these are important ones to remember because they've been the foundation of how we do and the definitions. So when you get the letter back from screening or an ophthalmologist with just acronyms and no actual words, I know, it's this is kind of what we're talking about. So diabetic macular edema, or DMO, the ETDRS, slide's looking terrible as it is. I'm only realizing it as I'm looking at it now. But ETDRS was the study, and it defined what is clinically significant macular edema. So this is macular edema that is going to cause vision problems if we don't treat it. So you can have swelling and leakage in different parts of the retina, and we will just ignore it because it won't have any visual consequence. But this study defined that if these things occur, then it's going to have visual consequence and we have to intervene. And the study recommended at that point in time that the way we intervene is by lasering, so ablating bits of the retina. Over the years, so over the last 25 years, the type of laser, how we do it, the spot size, the spacing, all of that has been finessed. And so we use less intense laser, greater spacing, have less of an issue in terms of treating it. But it has been, up until very recently, just been laser, and it was established over 25 years ago. And in that time, doing this laser on this definition that was established by the study halved the risk of moderate vision loss. So that sort of halved the likelihood of going from 6/9, which is driving vision, to 6/18, which is not driving vision. And that's a big functional difference in the working population. So early laser, established by what we used to call clinically significant macular edema, halved the risk of moderate vision loss. It was a win in the 80s. And then you've got peripheral diabetic retinopathy. So this is in the peripheral retina, which is not so important for, functional day-to-day reading, writing, vision. And you have different stages of retinopathy. You can have microaneurysms, blot hemorrhages, exudate, and then you go on to venous beading. You will see on the image on the right-hand side that the vein is wobbly. It looks like a poorly made sausage roll, and that's what venous beading is. And you have intraretinal anomalies, ERMA, and that's the little squiggly blood vessels that are all kind of going in the wrong direction. And then you've got your dot and blot hemorrhages. And then you can have something like this, which is clearly just wrong. That's new vessels. It's awful new vessels, and they come up into the vitreous cavity, which is in front of the retina, and they bleed. And they also grow in the wrong places, and they can make an eye blind by pulling the retina away and things like that. So peripheral diabetic retinopathy can be ignored for a period, and then it really can't be ignored. And what we want to do is not get to that period, that region where you can't fix it. So the same study established mild, moderate, severe, and very severe retinopathy based on all these different clinical parameters, and then what we should do, when we should follow them up, and when we should intervene. So again, it was very clearly outlined, and most Commonwealth countries would use this, and so it was kind of a very good standardized way of managing our diabetic patients. And then when it came to proliferative diabetic retinopathy, which is really when we intervene with laser treatment, or if they've had a bleed, to physically go into the eye, remove the blood, and remove the jelly that the blood's sort of bled into. That's the high-risk proliferative diabetic retinopathy group. So laser treatment to the peripheral retina is really the cornerstone of new blood vessel growth, and still remains the cornerstone of management of new blood vessel growth. And it reduces the risk of severe vision loss. So severe vision loss is like you can count fingers a meter away. So it reduced the risk of severe vision loss by 50%. So it was a big deal. In those days, we used to ablate all of the peripheral retina, so there was like nothing that could happen to it because there was no retina left in the periphery. But now we've got less damaging lasers, smaller spot size. The laser is not without consequence. It does affect your night vision. It does affect your peripheral vision. So that's why we don't do it in everybody. You do it when you absolutely have to. And so this image, you can see a little laser burn. So you can see all the funny new blood vessels that are not supposed to be there. That's the really squiggly ones. And then the darker spots are the laser burns that we do. And you aim to have, in the old lasers, about 2,500 burns. And the new ones, you have to do about 6,000 to 7,000 burns to really get on top of disease as bad as this. But you can titrate it. So what's changed? So this is the biggest thing that's happened, certainly in my consultant lifetime. And there are two things that I think have completely shifted the way we're able to treat vision-threatening consequences of diabetes. One is advances in retinal imaging, and the second are these anti-VEGF injections, which you will all be aware of because we're practically injecting everything at the moment to do with the back of the eye. So let's talk about retinal imaging. Before, I used to have to look at this image and try and figure out whether the macula, which is just a bit left of that nerve there, is swollen or not. And I'd probably say, yeah, it's a little bit swollen, I'm not sure. But now I have the OCT, which is amazing because it uses light, reflectance patterns to basically form an ultrastructural image of the retina and the different layers of the retina. So this makes life so much simpler. And the main thing is that it allows us to pick up diabetic macular edema before it's awful, vision compromising, and much more difficult to treat. So this is a normal OCT of the macula. It's flat like a pancake with a dimple in the middle. And then if you look at diabetic macular edema, this is what it looks like. Now the top image is a no-brainer. I can look at that and say, well, that's clearly swollen when I look in. But the bottom one is not dissimilar to the picture that I showed you. So the patient may have 20/20 or 6/6 vision, and I may see a blood vessel, but I wouldn't actually pick up that degree of abnormality, that little bit of leakage. And then it would progress to the top image before I would actually be able to pick it up. But with the advent of OCT, we can pick up this disease process and treat it before it gains momentum. The second major advance is wide field imaging. So this is that same picture again. It's about 30 degrees off the retina. And now what we've got is this. So 200 degrees of the retina on a single image. So the wide field imaging has probably made ophthalmologists slightly lazier, but also also allowed us to really target our treatment, because with this imaging we can do wide field angiography. So we inject blood fluorescein into the blood vessel and take pictures of the back of the eye. This shows the areas that I could image prior to wide field angiography, and you can see the different circles when the patient looks up, down, right, left. These are all the areas that we can actually image. But in this angiography, you would have completely missed those new blood vessels in the far periphery that are leaking. And also, if you look carefully, you'll see that there's no blood vessels, and that it sort of gets truncated. And that happens in the context of diabetic peripheral retinopathy. And so if I laser it here, then I may actually stop the progression of it going completely pear-shaped, but I wouldn't have been able to pick it up without wide field angiography. So it allows us to diagnose and monitor proliferative disease at a much earlier stage, and then it allows us to target our laser treatment, because I can then use that angiography and only laser the areas that are problematic and stop that cyclical process of progressing diabetic retinopathy. The rest of it won't need to be touched, and so that's been a huge advantage in terms of, again, stopping that diabetic retinopathy progression gaining momentum. And it does give really cool pictures. So this is that awful new vessel, and that's what it looks like. And you'll see that the rest of the retina has got no blood. The peripheral, which should have lovely vein-like sort of blood vessels, is completely gone, and then you've got this frond of new vessels that's leaking. So yeah. So imaging has been a big thing. The second big thing are anti-VEGF injections. In my opinion, it is the single most significant development in ophthalmology in the last 10 years. Prior to that, medical retina, which is a subspecialty that I love, you just watched people go blind painfully in their central vision.
Narme, can you explain, because I asked you earlier what medical retina means?
Oh, right.
So just for those of us who don't work in ophthalmology.
Sorry, yeah, it's just a term. So when it comes to the retina, which is only really a small part of the eye, but we like to think it's the most important part, we divide it into surgical, where it's mechanical issues, things are being pulled up and not in the right place. You have to physically go in and put it back into place. Or medical, where you have to use other components like injections and you can't really treat it surgically. And so we didn't actually, in my time I've always had something, but prior to that you didn't really have ways of stopping it, stopping the diseases that fall into the category of medical retina very well. And then sort of around 2000 we came up with various laser treatments that were not so traumatic, not the laser burning, to try and mitigate some of the disease process. And then in 2004, people came up with anti-VEGF. So this targets vascular endothelial growth factor, which is responsible for vascular permeability and the development of new blood vessels, and it stops it basically. And there are 3 available in the market. Bevacizumab or Avastin, which New Zealand's used from day one, mainly because we're relatively poor compared to some of the other countries that have been using the other two. Ranibizumab, also from around 2004, 2005, and that's the proper one that's been used in all the trials. And then most recently, from about 2010, aflibercept or Eylea, and they all target anti-VEGF. They are just formed slightly differently, and they all work to the same effect. But aflibercept or Eylea is supposed to be like the Viagra of anti-VEGF. You know, it lasts longer and is more strong. But I'm not sure. But anyway, that's kind of how it's marketed. Yeah, it's given directly into the eye. There's no pleasant way of saying this, but it's not actually as bad as it sounds, and the eye is numbed. And so all three are 0.05 ml of the drug is injected directly into the eye. It's an aseptic technique under topical anesthesia with iodine being preferred method of antiseptic. And we use a needle, which is 30 gauge. Some Australians use 32 gauge, but sometimes it bends a bit. Yeah, we inject in a particular area so you don't poke it into the lens or poke it into the retina or somewhere else that you don't want to put it into. The other unpleasant thing is that it has to be done on a monthly basis. So you will understand that you go from having no treatment apart from the occasional laser to having to treat patients every month to preserve their sight. But I'll go on to that in a bit. The injections are relatively safe. We quote a 1 in 1,000 risk of infection because something from the outside is going in. In reality, when you audit the results from Auckland, it's much less than that. It's about 1 in every 2,500, but 1 in every 1,000 is kind of the general quoted risk. You can have cataract formation if you touch the lens with the needle, and you can have retinal detachment if you put it in the wrong place, and other issues like blocking off the retinal artery because too much volume has been injected. All of this came around because bevacizumab or Avastin was used to treat gastric cancer, and then it was found to have a beneficial effect in this context, and then they diluted it down to a small dose. There was an initial concern with all of these drugs that there was a higher incidence of heart attacks and strokes, because that's what happened with the very high doses of Avastin that was used for GI cancer. But there's been very good safety data now, and it's not an issue. If someone has had a stroke, we have a 6-week to 3-month stand down period. But again, that depends on if you're fighting for an only eye, and this is important for preserving vision versus, you know, there's other clinical factors that you take into account when you're making those decisions. The safety in pregnancy has not been established to date, but Avastin's been used in premature babies to treat retinopathy of prematurity, and so far it's been okay. There's a lot of data in saying how great this is in diabetic macular edema. It is now the standard of care. So we still do focal laser. I think I hate to say it, I'm still old enough to do focal laser. Some of the newer generation are almost exclusively injections, but I do still think that for macular edema there is a role for focal laser, but most of the time it's anti-VEGF because there's no disruption to tissue. You're just closing off those blood vessels. You're not destroying any of that precious central retina. There is emerging evidence that we should do it for the new blood vessel growth in the periphery as well, but the jury's still out on that, mainly because it's a never-ending process. You know, injecting patients every month for this is a killer for the patient, for the health system, for the nation's resources. So I think we have to be a bit careful about what practices we adopt in terms of the global picture of managing diabetic retinopathy. There is a really good network established in America that's looking into this constantly. So there is a good body of data constantly being churned out to guide where we're heading with this, but it's rapidly evolving. So you know, every couple of years our management is changing in terms of what we're doing in this context. This is just a list of all the various studies but it does, and we like our names. We like our little acronyms. Resolve. I know, right? They are Vivid Vista. No, it's all great. But all of this basically says that you should be using anti-VEGF. So how good is good? You'll remember with the laser, it said that it limits the moderate vision loss. But in that same study, 12% still lost more than 3 lines of vision. So our best case scenario with what we had with macular laser is just status quo, maintaining it. But in looking at these anti-VEGF, we don't just maintain it, we improve, we restore that vision. And that's been a massive change in what we can do, which is why we keep injecting these patients. And you do have to keep injecting them. It's not just one. Most studies, you needed, ongoing monthly treatments was the management regime that they looked at. And in the Eylea study, which goes for longer, so, for 2-3 years, again, the benefit is lasting. You go from laser, which is just status quo, to a dramatic improvement in vision. So that's getting people from non-driving to driving vision quite comfortably, and then maintaining at that. But you have to keep injecting them to maintain that. So that's the sort of situation that we're in at the moment.
Now, once they're doing well, if you stop injecting them,
yeah,
do they go back to where they were previously, or do they worsen?
So it's quite variable. I've got a slide on that. It's a really good question. And do you know what? It's a question that I don't have an answer to that is global, because some patients, and you could argue that it's to do with their glycemic control, their blood pressure control, if they've got another insult with like a vein occlusion in addition to the diabetic. Any number of things will cause it to relapse. And so over the years, we've got a way of just doing, I'll go on to that in just a second. So the clinical trials, as I said, there are 3, Avastin, Lucentis, Eylea. The clinical trials have used Lucentis and Eylea, as have Australia and New Zealand, UK exclusively. Avastin has only ever been off-label use. It's not approved for use in diabetic macular edema, and there's a massive cost differential. So in Auckland, we compound Avastin ourselves, and it's close to $20 to maybe $80 per injection. Lucentis is $2,400, and Eylea was $1,800, and the price has just come down now. So it's a big difference. And New Zealand hospitals have only used Avastin up until quite recently. There's only in 2015 was the first head-to-head comparison between all 3 in diabetic macular edema. And New Zealand could say, oh, well, it doesn't really matter because we were okay all along. There was actually no difference, no clinically meaningful difference between the 3 in terms of how they work. If you did a subgroup analysis, then those with poorer vision, indicating worse macular edema, did do better with the Eylea. But there was definitely no difference between the Avastin and the Lucentis. So I think we did a good thing. Off-label use of Avastin allowed us to treat a vast number of patients without completely destroying our health resources in that time. So how often and how do we go about doing this? This sort of pertains to your question. So these injections are used for a number of different retinal conditions, and they're all slightly different. So the answer to that will vary depending on what the conditions are. So you can't take this as a global answer to the injections. The trials have looked at monthly injections, so keep injecting them every month, or as needed, so when it goes bad, treat it. Or this thing called treat and extend, where you inject till it's stable and then you slowly extend the interval between the 2. And for, say, macular degeneration, which is one of the other common conditions, I almost exclusively do treat and extend because I think it's always going to come back and it's being proactive. But in diabetic macular edema, it's slightly different, and I think it's quite reasonable to do 3 monthly injections. And if it's completely resolved, then you can just treat as it's needed, provided they come back to you. Often it's not completely resolved by 3, and the average is about 9, which is pretty much the course of a year. And so you find that you do tend to treat and extend, and then have to monitor them, and then at some point it'll come back, and you can't quite predict it. So in New Zealand, we started doing these injections for diabetes around 2014. We were doing them for macular degeneration earlier. We've only really used Avastin up until recently. It's very clinician guided as to how it's done. Pretty much everyone will stop injecting when the diabetic macular edema is resolved and just watch. I think very few people will just keep injecting as a preventative. And since June of this year, it's been a massive breakthrough. But Eylea, the other one, which is slightly better affinity and has that benefit in worse diabetic patients, has become available on Pharmac Special Authority. And that can be delivered in the community or in hospital. So that's been great. That's a big win in this context. Before that, Lucentis was available in very special scenarios and mainly only at Auckland, and not for diabetes. We were very limited in what we could do. So the Eylea thing has been massive, actually. The main thing is this massive treatment burden. It's huge because the amount of diabetics is increasing, everyone's living longer, and we're finding more and more intensive ways of controlling it. We have, as collectively as a group of ophthalmologists, I think, done very well to utilize other ways. So the imaging, we've done virtual clinics, so it's not just the screening that's in the community, but you can come into these sort of intermediate clinics where you can just get a wide field image or an OCT and don't really need to see a specialist, and just can be monitored by that. We've also changed the scope of practice of a lot of our allied health. So we've actually got nurses trained that we all train to do the injections, so that the decision is made by us, but the actual injection is delivered in the hospital, for example, by nursing staff for these anti-VEGF injections. And then, of course, there are these robust screening guidelines and implementation of that, which, despite some criticism, New Zealand does very well, because it's really picking it up before it's so established that it's going to take so much more for us to treat it. It's not perfect, it's not unified through the DHBs, and I think an OCT scan should be part of the screening, and it's not, but it's very difficult to integrate that into it. But I'm hoping that that's what we'll work towards as the next step. So finally, future. The future, I think we're all going to be replaced by robots, basically. I think I actually wrote that. Yeah, we're all going to be replaced by robots. It's interesting. I actually have some very good friends in America who are very involved in this. So you've got deep learning in the context of machine learning, where basically you can show a computer a few images and what the outcome is for those images, and then it sorts itself out as to what parameters it needs to look at. And where we are basically is this publication, which was a couple of years ago now, did a head-to-head comparison. It just showed some pictures from databases to 8 ophthalmologists, retinal specialists, and a computer, and it was practically the same outcome. And so it showed that these computers can and artificial intelligence can establish algorithms without a great deal of input from us to correctly identify stages of diabetic retinopathy or diabetic macular edema. And there are already retinal cameras being established where this algorithm will be built into it. And so you will get to a stage, I think, where you'll come in, have a picture, and have a management pathway already done, without having input from an ophthalmologist or an eye care specialist. And I'm assuming this would be community-based, and it's scary, to be honest. It is quite scary, but I think there is potential for great benefit in this form of disruptive technology, because we are lacking manpower, and if the computers can do it just as well, and streamline the patients, then it might get us over this this hump. So I'll just finish up with, I hope I highlighted how integral the primary care physician is in terms of in the management of diabetic retinopathy, and really initiating that screening process, and also very much so in that risk factor modification, identification and modification. We have very well established classifications and managements for diabetic retinopathy, but the better imaging and the screening that we've got means that we're getting to the disease before it gains momentum, which is important in terms of the treatment burden. The way we manage it has changed dramatically in 5 years, and that has resulted in us being able to improve vision just rather than hold it at bay, and therefore return a lot of patients to good functional vision and good function in the community. The consequence of this is that there's been this exponential increase in demand in a very short space of time that all eye clinics around the nation are struggling to keep up with. And we're being sort of clever in trying to find ways of, fitting everything in, but it is genuinely a significant issue. And the future of how we screen for and maybe even manage diabetic retinopathy will change with artificial intelligence and the algorithms around that. They can go from just image recognition to actual care implementation. So I think the future is quite exciting in terms of that.
Well, thank you, Narme. We've got a few questions that have come in. The first one you partially answered, I think, around who does the injections, and you said you were training up nurses to do this as well. Is it just hospital-based, or can it be done in communities? What happens in our rural communities in New Zealand? So,
it can be done. It's not just hospital-based, so it's not necessarily a surgical procedure. I think it has to be done in a clean, sterile procedure room. The main issue in terms of who does it and what is to be able to deal with the consequences. And that is why it's, at the moment, for anyone who's not an ophthalmologist, the nurses are injecting with very close, like we're physically there. If you inject too much and you block off the central retinal artery, you need to be able to get the fluid out. Otherwise, the patient goes blind. Accountability on if someone gets an infection is there's lots of issues around that. So in terms of who does it, it's an ophthalmologist, but we're training up nursing staff to do it under a very close supervision of an ophthalmologist. The accountability still rests with us, as with any procedure, but the delivery is under our supervision.
And are the technologies that are available in terms of the imaging are readily available throughout New Zealand? Are they available in the South Island specifically? Someone has asked here.
In terms of imaging for screening, yes. The retinal screening, the fundus cameras, yes. The technology that I mentioned at the very end, artificial, that's not readily available at all. That is just in its infancy, and there's lots of companies trying to come up with algorithms as well as individual practitioners, and it will navigate its way over the next few years somewhere. But in terms of the way the screening happens, it is that DHB based, but in Southland, for example, it could be that there's a few optometry practices that have the fundus camera, and then the photos are sent to an ophthalmologist who reviews them and then gives back the screening report. So that would be a way in which it would happen. But yes, I would expect the fundus cameras to be available throughout New Zealand.
And which patients are particularly difficult to do the imaging on?
It's quite obvious when they try and take the photos, but anyone whose pupil doesn't dilate particularly well, and cataract. So the most common reason for image failure is a cataract. And that was one of in terms of the national criteria for having cataract surgery, inability to monitor diabetic retinopathy due to a cataract is an automatic override for getting onto the wait list for cataract surgery. You don't have to go through that point system that we have to. So that's the most common cause for it. Any surface issues is also a reason why the screening could fail. And when the screening is a red flag, for example, there are microaneurysms at the macula on the picture, but you don't know whether it's swollen or leaking, then you get sent somewhere for an OCT, which could be like a gateway clinic like we have in Auckland, which a nurse led as well under an ophthalmologist supervision, or it could be to an ophthalmologist, which is probably what happens in the more peripheral centres.
And there are a couple of questions around the role of statins, and what is the drug that is used in particular in Australia to reduce the risk of diabetic retinopathy?
So it's a fenofibrate. I don't know the trade name for it. And I know it's definitely not funded in New Zealand. And a statin, I think it's just general statins. I have not advocated using cholesterol lowering specifically for diabetic retinopathy. I think partly it's because I'm not sure if the evidence in its isolation is strong enough, and also it's not good when you've got renal compromise and a number of other factors. So in the scheme of things, it's of a lower priority than good glycemic control and blood pressure.
And someone's asked, has the fenofibrate decreased the rate of laser and injections in Australia in real world data?
So no, we don't know the answer to that, and it's not injections, it's just laser. That's the thing. It's reduced the risk of laser in the study that they did by 30%. So that's the only piece of information that we've got from those studies. I don't think the real world data, so there's a really good database called Fighting Retinal Blindness that is Australia, New Zealand wide, that all the injections and the results of that and the medications, everything are uploaded. But there hasn't been any information from that database on fenofibrates in that context. And I know that the endocrinologists here have not bought into it.
Advocated for it?
No.
Okay. Lastly, there's someone's written a question here, which is quite an interesting one. I'd be interested in making a business case for deep learning retinal checks in our practice of 18,000 patients. Over 50% of those are Māori or Pacific Island. How do we find out the cost for purchase or lease, or how do we get training and credentialing for clinical staff, and how do we sort of have a vision of this for the future? Do you know? Have you got any answers for this?
It's a great idea, and I hope this is where we're heading in the future. At the moment, there is no one program that is done, mainly because say, for example, in the little ROC curves that I showed, there was iDocs and Mesidor, which are two big eye image databases. But the reason there's no actual program is because we need a ton of data and for it to be validated. And so there hasn't been a trial. First of all, there's not enough data to have a clear algorithm, and then it has to be validated. So that process has to be done before you can put a business case to purchase it from somebody, because otherwise you don't know what your false positives and your false negatives are in this context and what you're missing. I know that there are a number of people working on it, big ones like DeepMind, Google, and there's also IBM. There's a lot of large companies working on acquiring images and processing it. And for example, the University of Washington looked at over 1 million OCT images to use OCT as a basis of diagnosis. And so what's limiting it at the moment is just having a collection of enough data. The more data you have, the better the algorithm is going to be, and it's going to be constantly learning. But I would not take anything on board unless it's been validated in a clinical study, because then the accountability is, it's off. Unless you can put it head to head against me or, someone, a retinal specialist or an ophthalmologist, and say, this will say this diagnosis and so will he or she, then, only then after that. So I think we're a wee way away. In the interim, there's a few ophthalmologists and, actually registrars are great in this, who are quite good with computer programming, who are trying to work on it. But you really do need large data sets, like really large data sets. So I think it'll come from overseas, and then it'll be built into a camera, the algorithm itself. So you'll purchase the camera, and then they'll come with any new purchase. Someone will train you for it, and then it'll just come out with a diagnosis and what to do after that. I think.
So watch the space.
I definitely,
What a great thought.
Yeah.
And a further question: I'm using Dermagene for skin lesions. It overcalls everything. Humans are still needed.
Yes.
we still have.
No one gives a hug.
Yes.
Or tells you off as much as a human.
Yeah. So as you say, I think it's I guess being able to know when these things are going to be available and watching for them coming through.
Yeah, I think so. And I'm part of a college, Australia New Zealand College task force that is looking at establishing policies, because the question that one of you asked in terms of where do we get one and stuff is important, because it needs to, the validation is crucial. I definitely think we should adopt it. I don't have any concerns about that, but I think we have to be very careful about what you adopt, and what we don't want 20 different ones out there, and all with slightly different, and the ethics around it is also significant, because what we have noticed is that you can look at a fundus image, and also there's enough data there to look at smoking status, blood pressure, duration. So the data it can get from looking directly at your blood vessels are quite significant. That has implications for people in terms of privacy, in terms of especially health privacy and things like that. So the ethics is also really important to be looked at before we jump into this, I think.
And that treatment burden that you've talked about as well. So once we discover everything, being able to then go on and treat people adequately and offering everyone the same.
That's right. And I think there is scope for that, because I was involved in a trial in AMD, which is looking at a much longer acting anti-VEGF agent, and also targeting more than one growth factor. So placental growth factor in addition to vascular endothelial growth factor, to have better efficacy and longer duration. So we're not doing it monthly. Eylea, for example, is the posology is sort of loading 4 weekly and then 8 weekly after that. Real world data shows that it's not quite 8 weekly, but definitely longer than Avastin. So that's a positive. And so I think there will be a lot of ways in which we reduce that treatment burden in the future with better agents. I think it's positive, but it's a little bit overwhelming when you've just finished a clinic.
Yeah,
yeah, that's right.
Well, look, I think that's all our questions for tonight. Thank you, Narme. There's quite a lot of information in terms of how we can be doing better or doing the best we can in primary care to help manage our patients and do better for our diabetic patients, and facilitate that joining of our secondary care and primary care management for these people. So thank you very much. We'll look forward to looking at the future. And I think Narme's details are at the bottom there to be able to contact her, and we'll put the links that she's mentioned in our references on our website. So thank you everyone for coming.
Thank you.
Thanks for having me.
Good night.